Well, thank you for the organizers for allowing me to speak. And I can tell you I've given lots of talks all over the world, and this is probably one of the most that I'm nervous about. I am talking to an audience full of experts. You all know more about this disease than we ever up on this stage could, would, or will, because you live with it 24/7. I don't. So please forgive my nerves here. So today we're going to talk about liver-directed therapies, and we'll go through sort of what they are and how they fit into things. As was introduced, I am a professor of radiology and surgical oncology, but I'm an interventional radiologist by practice. So what does that mean? I use imaging to treat patients for conditions. A lot of my practice involves cancer, and a lot of that cancer is metastatic neuroendocrine. So this is a typical day in clinic. So what is this? I'm looking at scans. So I'm a radiologist by training. I read imaging studies. And these are 3 of my patients, okay? The image on I'm a radiologist, and my left and rights are going to be totally screwed up. The big one on the image right is one of my patients that showed up. As you can see, there's a bunch of white circles. This is an MRI in the coronal view, so looking at you from head to toe. And basically, we can barely find a normal liver cell in there, okay? That's an example. The picture on the top is a CT scan of a patient that arrived in my clinic after having barely able to take his dog around the block because he was having so much diarrhea. And he lived far up north in Wisconsin, which is where I'm from, and couldn't even take his dog on a walk, and said, his medical oncologist finally referred him down and said, is there something that you can do? And the image on the bottom is a patient that showed up after a snowmobile accident, got into the helicopter, taken down to my level 1 trauma center, and oops, this was an incidental finding on a trauma scan. So I see the whole spectrum of patients, and you're shaking your head, yes, I know all of these patients, and these experiences are true, and we'll get back to what happened with those patients and how we treated these patients. But I wanted to start off with the Netter one, and we've seen this study so many times already, even this morning. And what I wanted to highlight is that there are 2 curves here. So the curve that shows this beautiful survival benefit that Dr. Wolin showed us was the early data, right? So it came out and we said, oh gosh, PRRT is amazing. FDA approves it, now we're using it. And we're using it all the time, and it's really supplanting all the other therapies that we're using. But when we had the follow-up data, the long-term data, what we found is that the survival benefit didn't bear out over the long run. And what we know about patients with metastatic neuroendocrine is that we're not in this for the short game. We're in this for the long haul. I see these patients for 10 to 15 to 20 years, right? These cancers are indolent. So over the long term, what Netter-1 showed is that the curves come together. So is PRRT really what we should be doing? So they've done all these post-hoc analysis to try to understand, well, which patients really would benefit from PRRT, because there certainly are patients that benefit. We saw it early on. And so this is one of the post-hoc studies. And so what I'll show you about the post-hoc study is, and again, these are Kaplan-Meier's, and you've seen them all day. And what I will also explain to you is on my slides, if there's this yellow writing in the corner, that's the article. So if you want to read it, take a picture and you can actually read the scientific journal article where this data came from. So a Kaplan-Meier curve basically shows you survival. So if it's straight across the top, that means people lived a long time. And if it goes down, then that means the survival isn't so good. So you want to be going straight across the top. That's where we all want to be, up there. And what they found is that patients that had PRRT, you can see the blue, those are all the blue got PRRT, those patients did better. And the patients that got octreotide did worse. Again, this is sort of the short-term stuff. But what are the difference in the blues? The difference are the blues, and which the dotted lines and the straight lines, those are patients that they quantified how much disease was in their liver. So did they have less than 25% of their liver replaced by tumor? Did they have 25 to 50 or more than 50? So how much tumor was actually in their liver? And what they found, as you can see, those curves look pretty similar. So this is shocking, right, to all of us. Why would somebody that had their liver almost completely replaced by tumor do the same as somebody that had very liver tumor burden? So this sort of baffled us. Why could this possibly be? And so what we decided and what we're thinking is, well, maybe we should be focusing on the liver disease, because maybe that really will splay out those patients and make a difference. And so what is the goal of liver-directed therapy? You've heard this term a lot before, liver-directed therapy. So what is my goal when I see patients? Well, one, I want to debulk the tumors and control symptoms, right? What is important to you guys? Symptom control. You don't want to have to be running to the bathroom. You want to be able to walk your dog around the block, okay? I also want to kill tumors. But in killing tumors, I want to preserve your liver function. I don't want to kill your tumor and kill your liver. I don't want to kill your liver and kill you because I've killed the tumor, okay? My other goal is, can I get you to surgery? Okay, we don't have randomized data saying surgery is better, but certainly if the tumor's out of your body, we know somewhere between 60 and 90% of the tumor, if we can debulk it, that's better. So can I somehow get you to surgery in some way, shape, or form? Also, I want to be able to prolong the time between your systemic therapies. So we know that we have a handful. We don't have an enormous amount. So is there a way that I can keep you on octreotide for a little bit longer so we don't have to shift into one of the others? We don't have to go to sunitinib. We don't have to go to everolimus. If I can keep you controlled for said period of time, then we know at some point you're going to progress on systemic, but can I prolong how long it takes before you start progressing? And the last thing I'll say is I want to do no harm. So with my therapies, I don't want to hurt you, which would prevent you from going on to get additional therapies. So these are all the things that I'm thinking when I'm seeing patients in clinic. And so there's an alphabet soup, just like there is with everything else, of IR. When you come into my office, do I do TACE, DEB, TACE, TARE? What do all these things mean? So TACE, or transarterial chemoembolization, you'll hear us talk about this, is when we take a drug, we mix it with an oil, and we infuse it. And I'll go through these all individually, but I just want you to have the nomenclature first. DEB TACE is drug-eluting bead chemoembolization, transarterial chemoembolization. So what that means is I take a little bead, and I put drug on it, and then I infuse it into your arteries that supply your liver, and we'll talk about why I infuse into liver arteries. Then there's TAE, T-A-E. We also call it bland embolization. That's transarterial embolization. With that, I'm putting a catheter into the artery that supplies your liver, and I'm just injecting beads. It doesn't have drug, it's just a little bead, and it's gonna block off the blood supply to the tumor. And again, we'll talk about why that works. And then TARE, or radioembolization, Dr. Woolen talked about beta emitters. Okay, this is my way of giving you a beta emitter locally to your liver, transarterial radioembolization. I just saw some history there. There's a picture of Dr. Yamada. He was the one that did the first chemoembolization in 1977. He was in Japan. I had the pleasure of speaking with him. He actually sent me an email on my birthday. I invited him to a meeting. He said yes on my birthday, so it was my best birthday present ever. The rest of the alphabet soup of IR, I'm not going to talk about a lot of these therapies, but you should know what they are. So PER is percutaneous ethanol injection. That's where we would stick a needle into the tumor from the outside of your body, and we would inject alcohol, and that would kill the tumor, okay? RFA, radiofrequency ablation, we would stick a needle into your tumor, and we'd heat it up. How would we heat it up? We'd use radio waves. It's just a frequency of heat. It's thermal, it's hot, it gets hot, that's how we do it. MWA, microwave ablation, same thing, needle, heat. Instead of using radio waves, we're using microwaves. IRE is irreversible electroporation. We're sticking 2 needles in now, and we're sending a current between those 2 needles, and we're electrocuting anything in between. Okay, so these are all therapies that we use. Again, here's the history. That's Tito Lavrachi. He did the first ablation in the liver in 1982. The first ablation ever was done by his partner, Gigi Solbiati, and they did a parathyroid with alcohol injection. You can see we've come great strides from then. He's not even wearing a mask or a hat. He's just like put some betadine and then shoved a needle. Like, not sure that they would allow me to do that today. And then these are just the charter members of who really were the forefathers of my specialty, interventional radiology. So why is the liver different than any other organ? Why can we do this to the liver? Why am I able to put a catheter in and infuse things into the liver, but I can't do it to the kidney, I can't do it to the lung, I can't do it to other organs? And it's because the liver has 2 blood supplies, okay? It has the blood coming from the intestine up into the liver, and it has the blood coming from the heart into the liver. So why did our body make that? Okay, so the liver's job is to detoxify what we eat. So we all just had our little snack out there. And unfortunately, when we took the good stuff, we took the bad stuff. And so the body's way of detoxifying it is to make a network of blood vessels that goes from the liver to from the intestine to liver. So what we ate gets absorbed into the intestine, and then it goes through what we call the portal circulation, and then it goes to the liver, gets filtered out the liver, and then goes back out to the hepatic vein to the heart to get recirculated around. Okay, the liver really loves that blood. It's dirty blood, it likes it, it's got its nutrients, it's got its other stuff, and it can detoxify. Tumors don't like dirty blood. They don't like that at all. And at some level, the liver also needs oxygen, and oxygen comes from the artery, from the blood from the heart. So there's blood coming in from the intestine, and now there's blood coming in from the heart, and that's the artery. And so the tumor says, don't like that portal blood. I need artery blood. And so what happens is 90% of the blood supply to a tumor is from the artery, okay? And from the liver, 70% of the blood supply is from the portal vein. So you can imagine if I block off the artery, the liver's like, don't really care about that. I got this other stuff. But if you block it off to the tumor says, whoa, I don't like that dirty stuff, I'm going to die. And so that's why the liver is such a unique place where I can go in and do something, knock off the artery, but the liver survives. The tumor's dead, liver survives. It's because of this dual blood supply. And so this is what it looks like when we talk about this artery and portal vein. It's a very complicated network of blood vessels, okay? It's not just the artery and the portal vein. They're actually connected. And how are they connected? And there's this sort of very complicated network of blood vessels that goes around the bile ducts. And bile ducts are really important because that's how we get our bile out and made. And so it's really important to understand this because there's connections. And so I talked about debtase and tase. So the idea with debtase is that we infuse little beads into the artery. We block off the blood supply to the artery. But you can see at some level, and if I went back to that picture, there was those connections between the artery and the portal vein. And so the beads are getting stuck in the arterial system, but they're not deeply penetrating into the tumor. They're not crossing over into that portal vein, so you're not getting that both blood supplies at once. When we talk about liquid, or we do that where I mix the oil with drug together, that's what chemoembolization is. And that's, you can see, the liquid goes through the tumor, and then it goes to the other side, those portal veins, and it is able to really do a deep penetration and kill the tumor. And so those are the different modalities that we use when we treat. Radiation is very similar to that, and we'll get to that in a second. So this is what you need for chemoembolization. So what does it take to do that? And so what you're seeing in the syringe on the top is just oil. It's poppy seed oil. It's called Lipiodol. Okay, it was the first imaging agent we had here in the United States. It was FDA approved in 1906. Okay, before we even had CT. And so the three components you need when you do a chemoembolization is you need a drug, you need the oil, and then you need the embolic. And so why do you need those three things? And so when I talk to my patients about chemoembolization, what I tell them is think about coffee. I spilled some coffee on the ground and I have a hose. Okay, what happens if you put the hose on the coffee? It's gone, right? Coffee's gone, cleared away. Same thing if I just infuse a drug into the liver. What happens? The blood just washes it through. That's its job, right? It's a liquid. It doesn't get stuck there. So now what happens if I drop some oil on the ground, right? I have the hose. It beads up. Eventually, if that hose stays on forever, it will go away. So the third component is an embolic. And an embolic is basically those little beads I talked about. So what does the bead do? It turns the hose off. So I get the drug in there, mix it into like a sort of a pasty solution, and then I put something to turn the hose off so it gets stuck in there. So it gets stuck in the tumor, it can stay there, and it's effective. And that liquid can go across through the portal vein, and now we've got an effective kill of the tumor. So that's what we need for chemoembolization, those three components, drug, oil, and then something to turn off the hose, which is an embolic, okay? This is what it looks like when we infuse it. We make those little, we push those things back and forth with each other, and it basically looks like a paste or mayonnaise sort of consistency. And when I infuse it, I see these little droplets. And that droplet tells me that I did a really good job at mixing, okay? What about drug-eluting beads? So I talked about the bead that has drug on it. How does that work? It's basically the bead is negatively charged, the drug is positively charged, they stick together. As soon as I infuse them into the blood vessel, they come apart. Okay, it sounds really easy. It's very complicated to get those two things to happen, and how positively charged and how negatively charged, like a magnet, right? How strong is that bond? Okay, but these are just images of what it looks like, what these little teeny tiny beads look like. And this is what it looks like in practice. You have a syringe that comes down from pharmacy. They actually put them together, and then I draw it up into my syringe, which is when I am going to infuse it to you. Radioembolization is the same thing. It's teeny tiny little beads, okay? These beads are so small, it's not going to block off the blood supply. Okay, it's not going to block those arteries like that's first or second picture I showed you. But what it does do is it has that beta emitter, right? What's a beta emitter? It just sends out this radiation that will kill anything in its path. Okay, but the radiation only travels about 1 centimeter. So unlike external beam radiation where it has to come from an outside source in, this is from the inside, so it can only travel this far. So if you put it in the liver, it's not going to cause damage to the pancreas, the stomach, anything else in that area. It's just going to cause local damage to where I've put it. Okay, it can cause damage if it goes where I don't want it to go, in the stomach artery, which unfortunately comes off of your liver arteries, but certainly that's radioembolization. So really, what is the role for liver-directed therapy? And so this was a study looking at a large cancer registry in California. And what they did is they went through and they said, okay, let's look at all the patients that have metastatic neuroendocrine and were treated. So did they get systemic therapy alone, or did they get liver-directed therapy alone? And how did they do when we compared those two groups? They excluded patients that went to surgery. They excluded all these patients, right? If you had a different cancer, you had anything else. And so after, thousands of patients, they came down to about 154 patients that got ST, which is systemic therapy, or LDT, which is liver-directed therapy. And what they found is that who did better, okay? Well, the people that did worse were people that were not white, the people that were uninsured, and the people that had lung metastasis at the time of diagnosis. But what they found is that patients that had liver-directed therapy had a longer survival. Again, you want to be on that top curve. That top curve is the liver-directed therapies. And what about median disease-specific overall survival? So overall survival based on the disease alone, and those patients lived longer, okay? So again, this is a registry, right? It's not looking at individual patient characteristics. So what does that mean? I can't tell you what that means, but it certainly is compelling to me that says at some point in your course, if you have liver mets, you should be consulting about, should I have something injected directly into my liver to help with this disease, okay? So this is pretty compelling data. Even though it's registry, it's retrospective, we don't have any data. It's so compelling that we are actually in the guidelines, okay? So the NCCN guidelines also includes the option for hepatic-directed therapy in hepatic predominant disease. So if you have a bulky burden of disease in your liver, the guidelines say you should probably see an interventional radiologist, okay? It's there. Again, here it is again, NCCN guidelines, hepatic arterial embolization, including bland, TACE, tear. Now, you know what those things mean, right? And percutaneous thermal ablation. It's there, it's in the guidelines. Now, it doesn't tell us which one to do, and I'm going to go through why it doesn't tell us which one to do. But at some point, if you have liver disease, you should be seeing patients. So now, which one? Okay, we saw these curves before, and what we'll say is that line in the middle tells us if it's on one side, it favors one therapy. If it's on the other side, it favors the other therapy. So this was a study looking at should we be doing bland, and again, these are retrospective, so we're looking backwards. We're not putting patients and randomizing them. And it said, should we do bland or should we do chemoembolization? And what we find in these studies, and many of them, I'm just showing one example, is that there's not a difference in survival and how long it takes for your disease to progress, either inside or outside of your liver. So these are equal. Okay, so we don't really know, is bland better, is chemoembolization better? What about chemoembolization versus radiation? Again, this is a meta-analysis looking at all the studies that we have in looking at both. And what they found here is that there's no difference, okay? It's probably helpful to have it, but there's no difference, and we haven't shown superiority in one versus the other. This again looked at TACE versus radioembolization in a multi-center retrospective review, so we gathered a bunch of data from a bunch of different centers. And in this study, what they did find is that disease control rates were probably better with chemoembolization, okay? Again, the study is small. So we met as a group, the interventional radiologist, and we said there's got to be a way for us to be smart about this. We need to develop a study, a prospective study where we compare these things. But before we could do that, we had to understand where we were to begin with, because we had these small retrospective studies. So we compiled our data. We had 155 patients that we treated from 2004 to 2015. Now that's old data, right? 2004. I mean, we didn't even have lanreotide back then. We didn't have half of the studies that we have now. And we looked at all the different therapies. And what we found is that DEB-TACE didn't have enough patients for us actually to put in this retrospective study. But what we found is when we compared bland, chemoembolization, and radioembolization, there was no difference. Okay, so they did better, but there was no difference in any of the therapies. And so then we think, well, which one do we pick? So then we have to talk about, well, we should probably pick things that have less toxicity to the patient. And what these retrospective, again, studies have shown, and one was actually a prospective phase 2 study, is that patients had worse toxicities when we injected those teeny tiny little beads that had drug on them. Okay, so we said, well, that makes us think, well, maybe we shouldn't do that one. So there's 4 options, but maybe that one is one we should take out of our toolbox. And so we designed this study, a large group of us. It's called the RETNet study, so the randomized embolization trial for neuroendocrine tumor, RETNet. It is completed enrollment. There are 14 sites. I was one of those sites, and we are in the follow-up phase, and hopefully our data will come out in the next year. But what I can tell you is patients were randomized to 3 arms. So bland, okay? Chemoembolization and drug-eluting bead. And what we found, there's a big red X. That's bad, okay? The Data Safety Monitoring Board, after the first 30 patients, so 10 in each arm, so 10 that got bland, 10 that got DEBs, and 10 that got chemoembolization, what they found is that they had to shut down the DEB arm. So the little beads that have drug on them, they had to shut them down because they had such a high toxicity rate or adverse event rate that we couldn't continue the study with that, okay? So if you go to your interventional radiologist and they say, we should do drug-eluting bead, say, no, thank you. I don't want to. The FDA shut down that arm in the RETNet study, or go find a different interventional radiologist. Now, they shouldn't be giving you that therapy. But so the study now will show, when it reports out in a year, which one's better, bland or chemoembolization. And maybe it will show that neither are. Maybe it will show equal. But the benefit of this study is at least it showed us what our retrospective, it sort of proved what our retrospective study had told us, was that maybe the beads are not good, that have drug on them. Okay? What about afterwards? I said I don't want to do any harm. Do patients develop liver toxicity, or do their livers start to fail after? And what we know is that patients that have liver-directed therapy with radioembolization have a 14% chance of developing liver toxicity over the long term, okay, versus 3% in patients that undergo chemoembolization. Why is that? It's because it's radiation versus chemoembolization. I said that hose analogy. The hose washes the chemotherapy away, and it's not quite as toxic as radiation. But and here again, when we look at the actual toxicities, and we talk about toxicities as grading. So 1 and 2 grades mean, you have some fatigue, but it's not life-altering. When we get to grade 3, grade 4, and even grade 5 toxicity, that's a pretty severe side effect that you're getting, or toxicity you're getting based on the therapy. And what we found is that patients that had radioembolization had longer, worse toxicities, higher grade toxicities, 10 versus 8. Again, not statistically significant, but I certainly raises my eyebrows that, should we be doing this? And so in my practice, we sort of pull back on the radioembolization, and we will move forward and treat patients more so with chemoembolization or bland embolization, okay? What is it called when you have radiation-induced toxicities? I said maybe radiation was a little bit worse. We looked at our data, okay? These are a couple of studies that showed that about 20% of patients who undergo radioembolization for their liver tumors will develop liver failure due to the treatment, okay? We may cure you of the cancer, but you may end up having long-term liver toxicity, okay? So 20% risk if you get radioembolization of your liver that you're going to develop toxicity. Okay, here's another study showing about 30%. So this is something that we have to keep in mind when I said I don't want to do any harm, is that which patients are we selecting for radioembolization? Yeah, it's a great therapy. It works great. But I certainly don't want to be seeing you 5 years from now when you've developed ascites and varices and splenomegaly. Your spleen is big and you start vomiting up blood because I've damaged your liver. Okay, so we have to be very cognizant of that when we say, okay, should we or shouldn't we be treating patients? This is just, again, another subset of patients, 5% rate of death due to hepatic decompensation. And there are many interventional radiologists that will say, my patient had to go on to get a liver transplant because they went into liver failure. So 5% chance of death and 20% chance of going on to liver failure. This is real. So we need to be very careful about which therapies we're getting. So who is a candidate, and how do we decide which therapy we're going to get? Okay, patient selection is really critical when we talk about this. So there's a couple of different factors that I have to consider, and one is a patient factor. Okay, what is your performance status when you come in the door to me? Is it the guy that can't get out of his bed and is sleeping all day? Because if I were to treat him, I would make him worse, and I would have a 30-day mortality, when what that means is that his body can't tolerate what I'm going to do to it, and I would make him die faster than he otherwise would have. Okay, so that's really important. I have to understand that. Number 2, I have to understand, how is his liver functioning? For patients, oftentimes we'll use the child's puke score. Now that's typically used for cirrhosis, but many studies we look at it and we use it just because it's a way to calculate it. Okay, we'll go through that. I have to understand what you've had before. What has your body seen? What has your liver experienced before I go in gangbusters and saying, okay, and what is your life expectancy? Are we a grade 3? Are we a small cell? How quickly is this disease progressing, and how aggressive do I need to be, and how long are you going to be with me? Okay, that really comes into play. And then what is our goal? Am I trying to keep you alive as long as I can while maintaining your quality of life, or am I trying to get you cured? Am I trying to get you to the surgeon? Because those approaches are very different in my mind. And then there's tumor characteristics, right? What's the location of your primary? Is it a PNET? Is it an MNET? Is it carcinoid? Is it bronchial? Where is it coming from? Your Ki-67 and your tumor grade certainly are going to play a role in what I decide and how I decide I'm going to fold in my therapies. How much tumor is involved is really critical. How much of your liver is involved in this? What is the vascularity? Is there a lot of blood going there? I showed you those pictures that said 90% of the blood flow is coming from those arteries, but if it's not very vascular, my therapy probably can't get in there and penetrate that tumor because it's partially necrotic. And has it invaded into the blood vessels, okay? And then how much disease do you have outside of the liver? I can't put my blinders on and say, oh, I'm just going to go after the liver and forget about everything else. But I do know that the reason we go gangbusters over the liver is because ultimately, if the tumor takes over too much, your liver will fail and we can do nothing else. And that's why we sort of really go gangbusters against the liver. So these are the factors that we consider, okay? Performance status, as you all have heard this, is what does performance status mean? And I assess patients every time. Performance status of 0 is me. I get up in the morning, I take care of myself, I work full time, all these things, right? Performance status of 1 is you have restricted physical capabilities, okay? You maybe can't go for that 5-mile jog. Maybe you're not working full time, but you're still able to take care of yourself, okay? At 2, you're still able to take care of yourself, but you're maybe not where you should be, okay? But you're awake more than 50% of the time. I highlight those 3 categories because those are the 3 categories that I feel safe treating. Above that, I do not, okay? And at the bottom, I have there sort of highlighted and bolded that says it's really important what the slope is. So if I see you today and you're a 0, you're running marathon and you're doing great, and I see you on the day of treatment, and you say, gosh, I just can't get out of bed, I'm so tired, that's a slope, that's a rapid decline. And I have to understand why that happened. Is it because you started a new medication and that's making you tired? Or is it that the cancer is now starting to win? I can't treat you if the cancer is starting to win, or I have to do something to get you better because I don't want my therapy to be our ultimate demise because I've been too aggressive. So this is certainly very critical. And what we know is that when we look at overall survival, patients that have a lower ECOG status do worse. Okay, so it really does portend a prognosis, so it's really important for me to understand the performance status of patients. What about hepatic reserve? So I talked about the Child's Pugh classification. Again, this is for cirrhotics, but we sometimes use this as a surrogate in patients that have undergone other therapies. And this was actually developed to see surgical mortality in patients that have underlying liver disease. So patients that have liver problems, will they actually survive surgery? And this is how you sort of grade it. You just plug your numbers in and you figure out how many points you get. A child's A is good, a child's C is bad, kind of like school, right? C is bad. Okay, and what we know is that if you have worse liver function, your survival is worse. Okay, so we have to be very careful about what we do because we know we're already working with a disease that's pretty beat up. Now, I talked about you have to know about prior therapies, right? I had to know what you did. So PRRT, big one, right, came out in the United States, and now we're giving it to almost everyone because it's such a good therapy, or so we thought, okay? This was a retrospective review saying, can I give you radiation? And which, Dr. Wolin said, that's radiation you're getting, and now I'm giving you more radiation. And what happens when you put 2 radiations together, and oh my gosh, are we gonna hurt patients? And what we found is that it's probably safe. Okay, there's clinical toxicities in about 25% of patients. So yes, patients do have toxicities, but what we're finding is they're probably biochemical. And what that means is that maybe you're getting a bump in your blood work, but it's not manifesting clinically. So what we think is it's probably safe. Okay, here's just another one looking at a different platform using holmium. We don't have this in the United States yet, but it's just showing that patients are still able to respond to radioembolization after PRRT, so it actually works, and we're not seeing the toxicities that we were very worried about. But what we do know is that if you have PRRT after liver-directed therapy, it's also probably okay. What tells you that you're not going to do well or you're going to develop liver problems is if when you start those therapies, your liver's not functioning well, which just goes back to my patient selection. Okay, if your liver's not functioning and then we combine 2 therapies, not good. But if your liver's doing okay and we combine those therapies, you're probably going to be okay. Okay, so this just shows you that green line says prior liver-directed therapy did not portend a worse prognosis for PRRT. But what did is that pink line on the bottom was that if you had already problems with liver function, so your livers weren't working as well as they should be. Okay, again, NCCN guidelines, what does it say about the combination therapy? It says we have no idea. It says we don't know which should go first. We have no idea. So to be determined, and we'll figure this out as we go. The other thing I need to understand is if you've had prior biliary interrogation. So what does that mean? It means those peanuts, right? If you've had a Whipple, that's a problem, because what happens is when I go in and I try to kill a tumor, that the liver has bacteria in it because your bile ducts are now in continuity with your intestines, okay? If you've had a sphincterotomy because you had a gallstone back when you were young, all of that means that now your bile is contaminated. And if I were to go in and do a chemoembolization, an ablation, anything to your liver, a hepatic resection, your chances of developing an abscess or an infection are through the roof, okay? Like 800, 900 times higher, and you have a 25% mortality rate. So 25% of patients will die if I go on to do therapy, okay? So we have to be very careful about that. But what we do know is that if we do radioembolization, so if we treat you with radiation, your risk of infection is 9%. So I will certainly take 9% risk over 900% times increased risk of infection. Okay, so if you have a prior sphincterotomy or something where your bile ducts have been interrogated, that's really important, and we need to know that. Okay, what about the location of primary tumors? We talked about this before. I need to know where your primary tumor is because that's going to affect how long you live. Bronchioles versus MNETs versus carcinoid, all of those. And then we look at grade. This was our data from MCW, and what we found is that survival is different by grade. We know that. You have grade 3, your survival is less than if you're a grade 1. The other thing we talked about is tumor vascularity. So if I can get my treatment in there, you're going to do better, okay? And this just bears that out with data showing that if you have a hypervascular, meaning more blood coming into your tumor, you're going to live longer. Just data showing that. And this is a study just showing that on pathology. So what they did is they treated patients with radioembolization, so those beads that have radiation. They took the tumor out of a patient after they went to have resection, and they looked at those beads. Where were those beads? And then they drew little circles. And that circle tells you how hot or how much radiation those beads got. And what you can see is there's a huge heterogeneity. And there are areas in the middle there where that tumor's not seeing the radiation, right, because it only travels as far. And so what we have to remember is that tumor vascularity really can play a role in how effective we are at treating you. So I've just given you a lot of information, and I vomited out all of these, and the tumor vascularity, and the Ki-67, and the grade, and oh my gosh, am I a candidate or not? And what I will tell you is that I tell my patients, that's not your job. Your job is to get up in the morning. Your job is to eat, to see your family, and to live your life. Let me worry. I'm excellent. I'm the best worrier you'll ever meet. And you've hired me to do that, so don't worry about that. All you need to do is go to your doctor and say, am I a candidate, am I not? Let them worry. Okay? If you want to come in and say, no, Debs, yes, but let us do the worrying for you, because that's our job. So I'm going to go on and tell you back to those patients. So that first patient I showed you was 54 years old. He had really young kids, and he actually presented to the ER with chest pain. He had lost 20 pounds. He was skin and bones, okay? All labs were normal, despite that MRI that I showed you. He had no diarrhea or flushing. He just had early satiety, so he would eat and he'd say, I get full really easily. He was at ECOG of 0. He's taking care of his kids, still working. And he had a chest CT because they were worried about chest pain. And whoops, what's going on in the liver? They did a biopsy and his Ki-67 was 3%. Now, Dr. Wolin said, Ki-67 can be heterogeneous, right? We would say this is a G2. And we would say, okay, we're going to sort of step back and just see how things go. He had bulky liver disease, he had pain, and he was in what we call a catabolic state. He was losing weight. He was not going to survive if we weren't aggressive. So this is one of the cases where I said, okay, I'm going to do radioembolization. This is what his dotatate scan looked like. Black bad, right? He had it in his bones, he had it in his skull, he had it in his liver. This was bad, okay? And so he had about 50 to 70% of his liver replaced by tumor. You can see he had it in his bone. This is what that MRI looked like. I showed you that at the beginning. And his liver is actually down to his pelvis. When they did the CT scan afterwards, they had to go all the way to his pelvis. Like, oh my goodness, it was huge, right? No wonder he couldn't eat anything. So we did what we needed to. We did the volumes, and then we started him on Cape-Tem. So I did Y90, and then we started him immediately after on Cape-Tem. We need 2 weeks in between, and we started him on Cape-Tem. This is a picture 2 months after I treated him, and you can see those target things are kind of like not really able to be seen. And I just checked on him, just saw him, and this is 5 years later, okay? His liver kind of looks normal. You don't see those targets anymore. So again, multidisciplinary care, as Dr. Wolin talked about, we all have to be sitting at the table. This was a big effort by all of us. Why did we choose Y90? Because he was catabolic. And how's he doing? He's fine. He's taking care of his kids. His bony disease is better. He's gone on to have multiple therapies. It was not just me that did this, and look at me, I'm great. It was multiple therapies in combination. But 5 years after, you can see he's doing quite well. So patient 2, this was the 34-year-old I said that got into the snowmobiling accident, right? This was, oops, what is this thing? His Ki-67 was 5%. And he was another funny one. He said, I just always had a sensitive stomach. And his wife was like, yeah, he can't eat a lot of stuff. We just thought he was like anxious, and we didn't have any idea. And yeah, he turned red a lot, but we just thought that's how he was. Never even thought. And again, if he hadn't been in that snowmobile accident, he would have never known. He went in and got his primary resected. And at our center, we do transplants for patients with metastatic neuroendocrine. And so what we decided was that they wanted me to downstage him to surgery. Could we keep him in control, keep him in the liver, keep the disease small enough so that he could go on to get a liver transplant? So this is what he looked like after he looked like. And then this is what he looked like after I treated him. So I did a couple of rounds of chemoembolization, got those tumors under control. He ended up going on to get a liver transplant. But when they did the transplant, what they found is that he had, this is again after, and what they found is that he had positive cancer in his nodes, in his lymph nodes, which we weren't expecting, okay? And so now he's transplant, he's got nothing in his liver, but he does have small focal disease. And what I'll show you is that he developed shoulder pain. And so he's got a met in his shoulder. And so I know we're talking about liver here, but I can stick needles other places. I'm very good at it. And so I stuck it in his shoulder and I treated his disease locally. So when you have disease outside the liver that's symptomatic, we can go in and just stick a probe. I did microwave ablation, stuck it in there, burned it, and the patient is now cancer-free in his shoulder and asymptomatic now. So the last patient I'm going to talk about, this is a 53-year-old that had metastatic neuroendocrine. He initially presented in 1992 with flushing and diarrhea. He worked in a factory and he'd actually lost his arm because his arm got stuck in the conveyor belt. It was terrible. But never knew that he had cancer. He wasn't actually diagnosed until 2000. So it was a long time between the time that he presented initially and the time that he was diagnosed. He had a small bowel resection at the time. And then in 2012, he developed bulky hepatic mets, and the surgeon said, well, I'll take you, opened him up and said, whoa, that's not what I was expecting, and closed him back up, peek and shriek is what the surgeons say, and said, nope, there's nothing we can do. He had disease progression. He was symptomatic. This is the one that couldn't walk his dog around the block. He had little shelties. And he looked absolutely cachectic, right? He was thin. He was losing weight. He wasn't doing well. His chromogranate, I know we're not supposed to check that. This was before. This is really old because I wanted long-term follow-up for you guys. But his chromogranin were high, but his liver function was maintained, okay? He was an ECOG of 1 to 2. I think I'm giving him a little credit for the 1, but he was probably a 2. And this was that initial scan, okay? He had this bulky tumor. Now, CT is not great. It doesn't show you the extent of disease, but this is what he came to me with. And so we decided we would do a chemoembolization. This is what it looked like when I did it. That's the artery with all that gray smeary stuff, means that it's hypervascular, and at the end, it's that vascularity is gone. So he developed a very severe post-embolization syndrome. And that's what you get after these therapies, okay? I'm not saying it's a walk in the park when you do this. And what it looks like is a bad case of the flu. You can have fevers, you can have some nausea, vomiting, and usually lasts about 2 weeks. And he had that. He was so mad, he wrote me a 5-page letter, single-spaced with 10-point font, about how he hated me and I was the worst doctor that he'd ever met. In that letter, it said that he'd felt better than he had in the last 20 years, okay? In the 5 pages. So I was like, woo, a little win. Sorry. His chromogranin, I know we don't care about that, went down. But due to his perception of his post-embolization syndrome, he said, you're not touching me again. He walked his dog around the block many times. He went to Walmart and went shopping for the first time. It was in that letter. But he hated me. And I was like, okay, we'll deal with this. We'll deal with this. The problem is he had a central tumor. Okay, that tumor was sitting right in the middle. And what happened over time is that tumor came back and it started to grow again. And he started to develop damaged or dilation of his bile duct. And what did I say earlier about bile ducts? Oof, I'm scared of those, right? They're terrible. And so he came back in with dilated bile ducts, and his bilirubin was now 13. So my cutoff for treating you is 2. So 13 is really bad. So what we decided is that I went and talked to my gastroenterology friends and said, is there a way that we can decompress him? Because the tumor was compressing not where the bile duct enters into the bowel, but up higher. Was there a way we could stent just the bile duct above it and not cause that problem with the sphincter, and then I could go on to treat him? And so the gastroenterologist and I did this fancy thing called a rendezvous procedure, where I went in, put the wire down because he couldn't find where it was. He went up, and then we put a stent in there, and then we pulled out. Okay? And he went on to be able to get further liver-directed therapy because his bilirubin then went down to 1.4. So I say this because even though I said bile ducts scare me, we will go above and beyond if there's a way that we think we can get you therapy and we can get you something to help you, okay? He underwent Y90 radioembolization the second time, and he was able to, again, go out, walk his dog, and live his life, and his quality of life improved dramatically. He wasn't yellow, he wasn't jaundiced, and so he got symptomatic relief in the remaining 3 months that he had and lived. And so that just shows you how when you have collaborative, multidisciplinary teams, we can be very creative about how we treat patients, and nobody is not a candidate. We just have to figure out how to get you there. So this is sort of the algorithm I think about, and so if nothing else you take away, if you're symptomatic, when you include liver-directed therapy, we about have somewhere between 73 and 100% symptomatic control. Okay, we talked about all these other things that you can use, but certainly if we go in there and we can get that tumor to stop producing whatever it's producing to make you sick, we get symptom control. So think about it if you're having bad symptoms and you're trying all of these therapies and it's not working, think about liver-directed therapy, okay? We know that survivals are better. So what I'll leave you with is that liver-directed therapy has been shown to benefit patients that have metastatic neuroendocrine. It doesn't matter which therapy you get, except don't do DEB, not safe, not safe. According to the NCCN guidelines, we don't know if PRRT and radioembolization go well in hand, but early data does suggest that they're safe together. And I want you to also remember that we can do things outside of the liver. I've only talked about the liver, but we do treat disease outside the liver. So with that, I will end, and I guess at the panel, I'm happy to answer questions. Thank you.